In this module, we will discuss neoplastic disease. The name here literally means disease of new growth. And as we will talk about, this new growth is abnormal. We have abnormal cell replication and growth that can spread all over the body. In other words, we call this disease cancer, so that's the commonly known term. Again, in cancer, these cells have no limits for cell replication. They keep dividing and the number keeps increasing. The cells produced serve no purpose in the body. Actually, it takes a significant amount of nutrients and oxygen that should be used for supporting normal cells. Moreover, cancer cells can spread to remote locations that are different from the initial spot of growth. Cancer is a collective term that encompasses more than 100 different types of diseases. We have a lot of different cancers in different organ tissues, and collectively, cancer-related death is the second leading cause of mortality. The good thing, though, is that since the 1990s, mortality caused by cancer has been steadily decreasing in the United States. In this chapter, we will talk about the general aspects of cancer, including its etiology, pathophysiology, medical treatment, and the general principles for nutrition therapy. When it comes to specific cancers, we must assess the type of cancer and the specific treatment modality, as well as the patient's response to determine what would be the best nutrition care plan for that specific patient. We all know cancer treatment is challenging as it is still the second leading cause of death in the United States. So there are different organizations, for example, the American Cancer Society and the NIH, and they have worked together to put forward some general guidelines in cancer prevention. And this table here summarizes the recommendation from the American Cancer Society. If we look at the main recommendations here, it's pretty much a healthy lifestyle. A lot of the recommendations are already familiar because we have talked about the same recommendation in obesity and related diseases. For example, healthy nutrition, physical activity, stress management, and also a healthy community that provides the resources and access to nutrient-dense foods versus calorically dense foods. There are different signs and symptoms of cancer, and many of them are not specific. If we take a look at this table here, we see weight loss, fever, fatigue, pain, and skin changes. Many other diseases could cause the same signs and symptoms. So that's why many patients, when they first experience symptoms like these, they don't really think that they, maybe need to go get a checkup to rule out the possibility of cancer. They may just brush them off or think it's something else. However, if it is cancer that is causing these symptoms, without treatment, the symptoms will continue to progress and then the person's health will deteriorate. And that's usually when people really start to pay attention and then decide to see a doctor. But unfortunately, sometimes when they do seek medical assistance, it's already too late. They may be diagnosed with a later stage of cancer, which is associated with poor prognosis. So please go through this table carefully. A lot of these symptoms do have a common theme that the usual treatment or intervention does not improve it, or the symptom does not resolve on its own with time. So how does cancer start? Well, cancer, unlike, say, infectious disease, is non-communicable. That means that sitting next to a cancer patient or having a meal with a cancer patient won't give us cancer. And the etiology of cancer is a multifactorial process called carcinogenesis. So we have genesis, meaning the beginning, and carcino, right? And that is the prefix for cancer. So this is the beginning of cancer. And many factors contribute to this process. First, we have to be clear about the concept of carcinogens. Carcinogens refer to chemicals and other substances that can cause cancer. For example, if someone is exposed to asbestos, then that chemical specifically can cause a lung cancer called mesothelioma. Or if we eat maybe corn that has mold on it, and the toxin from the mold can lead to liver cancer. So these carcinogens could be from different microorganisms, or it could be synthetic chemicals that are man-made. Genetics play a vital role in carcinogenesis. The reason why cancer is so hard to detect early on and can be so difficult to treat is that every one of us, we have our own DNA, our own genome, and these carry genes associated with cancer called oncogenes. So we see here onco, as in oncology, the study of cancer. So oncogenes are in our DNA, but under normal conditions, oncogenes are not expressed. They're silent, or they're expressed in such a minimal way that our system can easily deal with whatever these genes are producing. So we know genetic expression leads to protein synthesis. So that's actually, similar as to what goes on for normal genes. However, oncogenes can exert effect on tumor growth by controlling cell division. Again, if oncogenes are overexpressed, then cell division may be accelerated and eventually get out of control. Then we also have tumor suppressor genes. These genes actually can cause apoptosis, which remember is programmed cell death. So they make sure that the cell has a mortal life, meaning that once their time is up, they will go through a series of events and eventually die. So all cells have a life expectancy, but cancer cells do not. So what happens here is these tumor suppressor genes become less functional, and that's when we have increased risks of cancer in our bodies. Right now, there are two very important disciplines of research that are connected with cancer. One is epigenetics, and this is the study of changes in gene activity that are not caused by changes in DNA sequence. This means that the gene's expression, whether it has been increased or decreased in terms of activity, it is affected by certain factors, but those factors do not change the DNA sequence itself. It's still the same genes, it's just the expression of it has changed. So in this figure here, we see the chromosome structure, right? We have this double helix strand of DNA, and we see that it is wrapped around a histone, or histones here. And histones may have different modifications. For example, it may have methyl groups or other groups, and this modification could determine if these genes are more tightly packed or if they're more loosely packed. Then all of that could lead to a different level of expression. So if we think about it and they're more loosely packed, then are forming the mRNA is going to be easier because we have better access to those genes. If they're tightly packed around the histone, we're going to see a decreased activity of that gene. And then also we have the second line of study called Nutritional Genomics, or in short form, nutrigenomics. So, this is the study of genetic variations that cause different phenotype responses to diet. So, for example, people are exposed to the same diet or dietary factors, but because they don't have the same genes, their body's response is different to that same diet. The study of nutrigenomics is not only useful in cancer, but also in other diseases, for example, in heart disease. So you may have discussed last semester that different genes determine if someone with high cholesterol will react better to a high fiber diet versus a low fat diet. Also, there have been studies that indicate, depending on the gene that codes for the ApoE, so that apolipoprotein E on lipoproteins, that could affect their cardiovascular disease risk. So this is a very important line of study. It actually can provide the foundations for personalized nutrition. For example, if we're talking about people with high cholesterol, we can test their genes to see exactly what therapies they would be sensitive to, so what would work best for them. Again, as an example, comparing a high fiber diet to a low fiber diet, or to a low fat diet, or adding more exercise. By testing their genes, we could determine which one or which combinations of these therapies would be more effective in helping the patient to lower their cholesterol. In the case of cancer, this can tell us that the patients with this certain genetic profile would react better to these certain dietary factors that could reduce their risk for developing cancer. So this is really a very hot area of research right now. Some companies have already developed a lot of genetic testing tools to detect the risk of certain diseases based on people's genes. And then dietitians will have personalized nutrition counseling based on the genetic testing results. So this is already something that's being done. And it's likely that the cost of these tests in the future will be significantly reduced. Therefore, more people will be able to have access to these tests, which would be great. So we are aware that there are nutrition-related factors that may contribute to cancer development. For example, the factors on this list are associated with increased risk for cancer. We see red meat consumption, certain food preparation methods, especially smoking, pickling, and high temperature cooking, total fats and the types of fat consumed, for example, trans fat. And there are others associated with high cancer risk as well. So overconsumption of alcohol, being overweight or obese is associated with certain types of cancers, for example, colon cancer. At the same time, we also have nutritional factors that have a chemoprotective effects against cancer, meaning that adequate consumption of these nutrients or compounds are associated with decreased risk for cancer. For example, as far as food groups are concerned, whole grain products and fresh fruits and vegetables are associated with reduced risk for cancer. And if we go to specific ingredients or chemicals within the food we consume, we see high fiber intake, vitamin D intake, and other phytochemicals are associated with decreased cancer risk. So in addition to reduced risk for hypertension, cardiovascular disease, and other diseases, consumption of these foods and nutrients are associated with a decreased risk for cancer. So it does take some time for cancer to initiate and develop. We mentioned cancer cells are characterized by unregulated cell growth and cell division. And because they have no limit in division and growth, they often invade adjacent tissues. At the same time, cancer cells tend to metastasize. So they spread throughout the body either through the lymphatic vessels or through the bloodstream. This is one of the reasons it's so hard to treat, because we may take out all the cancer in the original site, but by that time there may already be several colonies established in other organs or tissues, making treatment very challenging. So in this figure, shows from the moment where we have exposure to a carcinogen, and that could lead us to the initiation of cancer cells growing. So it can lead to the change of the DNA or the expression of certain genes. And as we can see, buried along a lot of normal cells, we have a few cancer cells here, right? These pink ones or red ones. So if the process continues with cancer into the cancer promotion stage, more and more cancer cells will show up, and eventually we get tumor formation. So here we see two types of tumors. And really, when we say tumor, it only means a mass of abnormal cells. It doesn't differentiate between being benign or cancerous. So in other words, malignant tumors, and that's what cancer is. Cancer is a malignant tumor. So if we compare between these two figures here, if the tumor is benign, we can see that although the cells have a different appearance from normal tissue, there is a very clear border here. So the border between the tumor tissue and the normal tissue is very clear, very smoothed and defined. Benign tumors are not invading the adjacent blood vessels, and they're not invading the adjacent tissue as well. So they're pretty much confined here within their own border. So that's one of the main things that's different. They're not spreading out. This is not the case for cancer or malignant tumors. For example, in this figure, we see here a lot of abnormal cells, but different from the benign tumor cells, we can see in this case that the cancer cells have already invaded the blood vessel. So we can already see cancer cells in the bloodstream. And imagine wherever blood flows, these cells can travel in the blood and establish new colonies in remote areas, so different tissues and different organs. This is metastasis. And if we look at the local invasion here, we can still kind of see the original shape of the tumor. But obviously, locally, these cells have already invaded beyond the border here. So the border between the normal cells and the cancer cells is no longer clear cut. It is diffuse and mingles with the normal cells. So this is why when surgeons who perform cancer surgery, when they really want to be safe and make sure that they cut as clean as possible. So they'll cut a certain margin. It may be, so say their margin's out here, right? So they may be cutting out these visually normal looking cells, but we still would want to cut wide enough around the cancer cells to make sure that we get rid of any of the cancer cells, even if it's just a few that have spread out beyond the original border. Other abnormal phenotypes in cancer cells include these listed here. So we have failure to differentiate. In many cancers, the cells look very immature. So remember, they're immortal. They keep growing and they don't mature. Therefore, their metabolism is very high. They take up a lot of energy, nutrients, and oxygen and deprive these things from our normal cells. They also no longer go through apoptosis. They just keep on living forever. So they keep on taking those energies, nutrients, and oxygen from normal processes. And a lot of them are genetically unstable. They may have mutations along the way. So this means that one type of chemotherapy agent maybe was effective against a particular type of cancer cells, but if these cancer cells changed over time, then that would make this chemo agent ineffective in the future. And because cancer cells grow fast, they divide fast, cancer tissue needs a lot of nutrients and oxygen, as I've mentioned. Therefore, cancer cells can secrete a lot of effectors that stimulate the development of blood vessels within the cancer cells. And this is angiogenesis. So angio, referring to blood vessels, and genesis, the beginning. So we can consider this the equivalent of building a highway in a new area that needs development. Because once the road is established and in use, then everything can come along it, and it's kind of, a logistic blood vessel. We can not only deliver what we need to the new site, but we can also get rid of waste from that site. And this last one here, so remember that all cancer cells come from within. It's not a communicable or infectious disease. It's because there's something wrong at the level of genetic expression. Therefore, although our cancer cells are abnormal, they're still our own cells. They're from our own genome, DNA, our own genetic expression. Therefore, it's very difficult for our immune system to recognize them. But we do have certain immune cells that can execute tumor or cancer surveillance. For example, those natural killer cells. Remember, this is the helper cell that does not need activation by the macrophages or T cells. They can just recognize cancer cells and destroy them. However, some cancer cells, they're, kind of sneaky. They can avoid being recognized by the immune system, so they escape this and keep growing, keep dividing, keep spreading out, and eventually cancer will develop. With the progression of cancer, the body will experience abnormal metabolism of macronutrients. Patients, especially towards the terminal stage, they will often have involuntary weight loss, and a lot of them will go through muscle wasting and malnutrition. And we have a term specifically referring to the malnutrition caused by cancer. It is cancer cachexia. You probably remember from last semester that term cachexia was brought up in congestive heart failure. That would be cardiac cachexia. So it's also a malnutrition condition. Because we already know that malnutrition is involved in weight loss and mass loss, and that it's associated with compromised functions at different levels, so we could see why with increasing weight loss, the death rate will also increase. So the more severe the cachexia is, the closer the patient is to death. And as dietitians, obviously, addressing malnutrition or cancer cachexia would be one of our priorities when we think about nutrition care for cancer patients. Whether it's pre-treatment, during treatment, or post-treatment, we have to keep in mind the main theme of cancer. Overall, it is a wasting disease. So how do we diagnose cancer? Well, with the development of technology and medicine, we can conduct many different types of tests. For example, we can do blood tests. We can check people who have high risk for skin cancer. They will have their skin checked by an expert on a regular basis, so that would be a physical test. We can check our blood serum markers to see if there are certain enzymes or certain proteins that are abnormally high, and this would indicate risk for certain cancers. Or we can do some cell tests to see the shape of the cells or to see the number of cells. And we can always do medical imaging. So CT, PET scan, MRI, all of these could help us detect that if there is a mass there. Biochemical testing, genetic testing, these are easy to understand. By doing all of these, what we want to find out is if there's cancer, what tissue type we're talking about. So we really want to figure out what the original source is. The original tissue of the particular tumor cancer would determine the treatment modality we choose. For example, certain cell types are sensitive to radiation. Then in that case, we may use radiation as the main therapy. Others may be sensitive to a combination of certain chemotherapy agents. So that's why different types of cancers, when a patient's going through chemotherapy, which we'll discuss later, they may have different plans from one another, a different combination of chemo medications to deliver the best results for that individual patient. Again, we want to know the primary site. Let's say that if we find a mass in the brain, is that something original in the brain that started there? So it means they're from brain cells, or is that maybe liver cancer that has spread to the brain? And this is important to know because, liver cells and brain cells, they have different biological behaviors and they are sensitive to different types of treatments. So extent of disease, we'll talk about this. We'll want to see how big the initial site mass is and if there's lymph node metastasized or if it's metastasized from the bloodstream. And also the potential to reoccur. Probably the most challenging part in cancer treatment is that many people, unfortunately, after admission, they have cancer coming back. And usually when it does return, that cancer does not respond to the original treatment as effectively. So what we're seeing here in this figure is showing a procedure called a biopsy. It's a biopsy of a mass in the breast tissue, the mammary gland here. So let's say that if during a self-assessment or an assessment by a medical professional, they find that there's a mass in the breast tissue. So then what would happen next? Well, they could use a special needle that inserts and penetrates the skin and eventually gets into the mass. So we don't know exactly what this mass is yet. So when it's inserted in there, we can apply a vacuum to suck out some of the tissue or cells. Then we can analyze the sample to see if this mass, if it's showing normal cells or somewhat abnormal cells or real cancer cells. So biopsy is a sampling process. Of course, if we find cancer cells, then that's a solid diagnosis. But what if we don't find cancer cells? What if we just find some normal tissue structure or normal cells? What does that tell us? Well, it only tells us that the biopsy only found normal cells. It cannot rule out other parts of the mass. So the mass may still contain cancer cells. So, maybe we just didn't sample from the right area, and this happens quite often in biopsy. So, although it is less invasive compared to other procedures, it doesn't work 100%. With all the tests, including patient's history and everything, we can reach a diagnosis of cancer. So right now, the medical field uses the TNM staging system to write out cancer diagnosis. So T stands for tumor, and it's talking about the primary site, so the primary source of the cancer and the size, how big that is. N stands for node, and it means lymph node because cancer cells, when they spread out, they can travel through the lymphatic ducts. So lymph nodes will actually enlarge and become solid and very hard. And actually, a lot of lymph nodes are superficial, so we could detect them through a regular physical checkup. For example, for women, when they go through breast cancer screening, in addition to checking their breast tissue, the healthcare professional will also check their lymph nodes in the armpits because that's a route for breast cancer cells to spread. So we definitely want to be checking that. Or we can also check lymph nodes above our collarbones and our neck area. These are superficial and can be checked easily to see if there's anything suspicious. And, metastasis, that we know as a fact that cancer has the ability to spread outside of the primary site. So if we have breast cancer, for example, that spreads out to the hip bone, or liver cancer that can spread to other parts of the body. Obviously, if we have metastasis positive or node positive, that is an indicator that the cancer is no longer at an early stage.